initiatives, join the platforms, join the communities of practice, create visibility for your work, and nothing is really an impossibility. I hope I answered.
Okay, Isaac, you may go ahead and translate her response if you're ready. Sorry, Israel, not Isaac. Okay, seems Mr. Israel is not ready. Emmanuel, Joshua, you can go ahead and ask your question.
Good evening. Am I audible?
Yes, you are.
All right. Thank you very much. Thank you so much for the opportunity to ask this question. My name is Joshua Emmanuel from Nigeria, a veterinary medical student. So my question is basically, as a youth leader, so what advice will you give to to seek partnership with FAO in driving AMR activities? Thank you very much.
Thank you. So I think Dr. Walter mentioned that you said you were a veterinary student in Nigeria, I believe. So your first point of call is usually the country office in your country of residence or your schooling. So in this case, FAO has an office in Abuja. Now, the reason why this is important is because in every country, there are several ongoing projects in different formats. There are projects that are specifically targeting the youth. There are times when FAO in the delivery of their projects will collaborate with your institution, for example, because they want to engage students, they want to conduct CAP surveys, they want to train students, they want to assist the university to modify their curriculum. It starts with your local, I would say, FAO office point. That will be your starting point. And then there are also those global platforms that are accessible to you, even from Nigeria, outside of your country office, that you can join directly. So once you have to find a way to create visibility for your work, but you can also always write to your FAO office, country office. You can introduce yourself. You can introduce your group. If you're a leader of a youth group, you can introduce your group. If you're someone who is developing an app and you want to promote that, you can always write to the FAO local office and say, I'm so and so, and we are doing this work, and you want to know what are the ongoing projects or activities. All of this is allowed. None of that is illegal. So these are some of the ways you can engage. And then in that way, you start building, you start interacting, and eventually partnership is not a one-day thing, but it starts from just having the conversation. And then at some point that may become a true partnership where you are actually jointly either to implement some AMR activity. I hope this helps.
Okay, sorry, I was offline. So, yeah,
Thank you very much.
il a demandé à savoir, en tant que jeune leader, quels conseils elle pourrait donner pour pouvoir avoir un partenariat avec le FAO dans le cadre de la résistance antimicrobienne. Et donc, elle a répondu que déjà, en tant que jeune leader dans son pays, et elle peut collaborer sur un projet avec le FAO et le FAO peut l'assister localement. Et également, il peut aussi passer par un mode de visibilité, avoir son groupe et en tant que leader, créer son plateforme sur les réseaux sociaux et essayer de joindre le FAO. Et le FAO peut éventuellement les assister dans leur projet dans la lutte contre la résistance antimicrobienne. Donc, c'est à partir de cela que ça peut devenir un partenariat. Ça ne va pas commencer directement par un partenariat, mais c'est tout un process. Merci beaucoup.
Okay, thank you very much, Mr. Israel. For the sake of time, we'll be taking one more question, just one more question, if there's any. Oh, we have a question. You can go ahead and ask your question.
Hello, everyone. I'm Mahir Tujo. I'm from Senegal. So it's not a question, it's just a contribution about the fact that we talk about TikTok and using social media to sensitize people. So personally, yes, I use TikTok to raise awareness about public health and of course against antimicrobial resistance. But sometimes there are some how to say some frustration because as an influencer, it can be frustrating to see that our governments don't invite us into this kind of program, and at the limits they invite influencers like comedians and this kind of people. So I think that even if we are trying to do our best, we need some support from our government. And also, I think that this problem about anti-resistance microbial is a little bit complicated if we don't have the support of government, because we need the regulations. Because we can see, I don't know in the other countries, but in Senegal, even the professionals are like doctors, they prescribe too many antibiotics, and also people can buy antimicrobial in offices without any prescription. So I think that we need to put some regular things to help for this fight. That's all I wanted to say. So thank you for listening.
Yeah, thank you very much. Indeed, you've summarized it well. Like I did mention earlier, we've made some gains. A lot has been done, but there's still a long way to go in terms of falsified medicines, quacks, in terms of regulation, in terms of awareness. But I believe that I hope that over the series of dialogues that you're going to have here, even as youth, you can begin to identify ways in which you can contribute. I know it seems a bit frustrating, but I would say start with organizing, making the youth groups more of an organized structure, and then maybe a bit easier for you to be included in some of these key meetings. But I can understand the frustration.
OK. Donc, du coup, cette dernière n'a pas posé de question, mais plutôt une contribution. Voilà. Donc, elle parlait du fait que dans votre pays, il y a pas mal même des professeurs, bien, quand vous parlez dans les officines, vous allez voir que vous pouvez avoir facilement un accès aux médicaments et les antibiotiques et sans vraiment de réglementation. Donc, elle pointe l'accent sur le fait de renforcer la réglementation pour pouvoir limiter l'usage facile des antibiotiques. Donc, c'est ce qu'elle a dit et, mademoiselle Esther a répondu que voilà, c'est vrai qu'il faudrait plus mettre l'accent sur cela et également former des groupes de lutte contre l'utilisation abusive des antibiotiques et un groupe assez structuré qui aura un suivi du gouvernement. Ça peut également beaucoup aider. Donc, en gros, c'est ce qu'elle a dit, c'était une contribution, pas une question. Bonjour, merci.
All right. Thank you very much, Mr. Israel. Ladies and gentlemen, that was Dr. Esther Disani from FAO. For the sake of time, if you have any more questions, ladies and gentlemen, please write them down in the chat section and we can have them being answered later on. For now, I will have to close the session, the end of the session, and I would like to hand over to one of my colleagues, the second moderator, Chantel, to take over and proceed with the second session of the night. Thank you.
Nous allons à la fin de la première partie de la session. Donc, autre modératrice va venir, elle s'appelle Chantel. Donc, c'est elle qui a la parole. Je vous remercie.
All right, thank you, Mr. Israel. Chantel, you can go ahead and take the floor. You can proceed.
Please, I have something to say. I didn't notice that someone asked questions, so I don't know if it's still possible to translate this question since this question is in French. I don't know.
Yes, you may go ahead and translate the question while we wait.
Okay, all right. So the question is, so first of all, good evening. My name is Abdel Karim Mahama Yakub. What mechanism should be implemented to combat antibiotics? That's the first question. And the second one, is it possible to perform gene transplantation or gene mutation in humans to limit or address this phenomenon? So that's the question they asked. I don't know. Can you hear me? Am I still audible? Can you hear me?
Yes, we can hear you.
Okay.
The question was the question directed to Dr. Esther. I think if it was, she can go ahead and answer.
Sorry, I was typing. Can you repeat the question, please?
Oh, okay. So the first question is, what mechanism should be implemented to effectively combat antibiotic resistance?
What mechanisms should be conducted to effectively combat antimicrobial resistance? So I will just emphasize. Okay, sorry, go ahead.
The second one, is it possible to perform gene transplantation or gene mutation in humans to limit or address this phenomenon?
The second question is beyond the scope of my expertise, but I will start with the first question. So,
all right.
to effectively combat antimicrobial resistance, we need to, as I said earlier, first create awareness among key stakeholders and engage them. And I mentioned that key stakeholders include not just government people sitting in the meeting, but also private sector, but also youth groups, but also pharmaceutical corporations and associated, all relevant stakeholders must be brought to the room. So stakeholder engagement is key. Second one is strengthening surveillance and reporting. And then we do this for countries by supporting them to build capacity in their laboratories to detect and report reliable AMR data that can be used for decision making. Then the third one is strengthening governance structures. It means AMR coordination mechanisms. This means AMR policies, national action plans. A lot of questions have been asked about regulation. How are drugs sold? How are they prescribed? Who is prescribing them? Access to antimicrobials and enforcing these regulations. So there's an element of governance structures. Fourthly, promoting good practices at all levels, whether it's in hospitals, whether it's IPC, whether it's on farms, whether it's biosecurity. So promoting good practices, ensuring hygiene in wards, hygiene on farms, developing guidelines. The last one is prudent use. So being good stewards, enrolling veterinarians, enrolling prescribers, doctors, physicians, anyone who is responsible for prescribing in some form of stewardship program, benchmarking programs. In this part of the world, we don't know, in other parts of the world, there are benchmarking programs. So doctors report on how much antimicrobials they've prescribed. And there's someone monitoring this to see why you're prescribing so much or why you're prescribing this category of a last line antimicrobial. So we don't have benchmarking programs, and stewardship is still very much lacking. If we can find a way to, in our own small way, accomplish all of these, then we would be able to manage the problem of AMR very well. This is the globe. This is in alignment with the global action plan. Now, coming to your second question on humans being able to or science or research to mutate genes on AMR, like I said, is beyond the scope. What I do know is happening is that we are also enhancing our lab work on AMR. There was a time when a lot of it was on ASTs alone. Now we are doing a lot of genomic work, genomic sequencing. I know some of you here may also be lab-based researchers, and we are trying to use bioinformatics to understand AMR better, at least to understand transmission in different environments, to understand the drivers. So this is how we are using genomics or genomics research to understand the problem of AMR better, so that we can have more targeted interventions rather than just designing programs based on primary research. Yes, this is what I can say for now. Over.
Okay, all right. So let me translate into French, then we will go to the second session. So, votre première question qui est de savoir comment lutter contre, quelle stratégie mettre en place pour lutter contre la résistance antimicrobienne. D'abord, il faut une assistance très tôt, déjà dans le secteur public pharmaceutique. Si la personne est souffrant d'une résistance antimicrobienne, une prise en charge très tôt est idéale. Également, au niveau de chaque pays, il faudrait que chaque gouvernement mettre en place un programme pour lutter contre ce phénomène, un programme bien défini. Et également, il faut une coordination et sur le plan national, comme je l'ai dit, mettre une politique en place et lutter contre ce phénomène qui fait rage. Et une bonne promotion et une bonne pratique de l'usage des antibiotiques peut beaucoup aider dans la résistance antimicrobienne. Et il faut également de l'hygiène. L'hygiène dans beaucoup de choses qu'on fait. Vous savez, l'hygiène peut permettre à ce qu'on va moins utiliser les antibiotiques. Également, si possible, former les prescripteurs et ceux qui délivrent les médicaments dans les officines, les vétérinaires. Il faut une bonne formation des prescripteurs qui pourra également nous aider pour éviter ou diminuer les effets liés aux résistances antimicrobiennes. Par rapport à la seconde question, elle a dit que, bon, d'une manière générale, il n'y a pas une réponse précise pour ça parce que, bon, c'est vrai qu'ils sont en train de faire les recherches actuellement sur l'intervention, comment utiliser les gènes pour lutter contre les résistances antimicrobiennes, mais pour le moment, c'est en cours de process. Ils sont en train de faire leurs recherches sur ça et ils sont en train de voir comment ils peuvent l'utiliser pour lutter contre la résistance antimicrobienne. Donc, en général, c'est ce qu'elle a dit. Je vous remercie. So we can go, I can give the floor to Ms. Chantal, then we can go for the second session. Thank you.
Okay, thank you, Mr. Israel. A good evening to you all, and thank you for joining the session. So for our second session, we're going to be having a different speaker. So our speaker for this session is Dr. Oluwatosin Ajayi. I hope I pronounced that well. So just a brief background about Dr. Oluwatosin. So she is a research analyst with One Health Trust. So she's a passionate researcher and an antimicrobial advocate. So for those who do not know what One Health is and what it really is about, so One Health is an organization focused on enhancing public health and global health through research and collaboration. So that's why she's the research analyst of that organization. Also, she's led and supported a lot of antimicrobial resistant projects that have been happening globally, internationally. Yeah, she's involved in that. And in terms of her professional or academic background, she holds a Doctor of Veterinary Medicine degree and a master's degree in veterinary public health and prevention medicine. So for this session, our topic is going to be antimicrobial resistance through time. So this is we're going to be learning from the past and strengthening the current action in Africa, how we are going to advocate for antimicrobial resistance in the future. So right now I'll give the floor to Dr. Oluwatosin Ajayi so that she takes us through this session. Yeah, thank you.
Hello, good evening, everyone. Can you all hear me? Am I audible enough?
Yes, ma'am.
You can hear me,
We
right?
can hear you. Yes.
Okay, thank you. So good evening, everyone. Oluwatosin Ajayi Olubamiṣe, based in Nigeria, and I'm actually a research analyst with One Health Trust, an organization based in the United States, which is also a WHO collaborating center. So I'm so excited to be here among young people like myself this evening. And I say a very big thank you to the organizers of this conference for inviting me, and to everyone who is actually a part of this. So the topic we are looking at this evening is AMR through time, learning from the past and strengthening the current action in Africa. So that's what we'll be looking at this evening. So I try to divide the discussion into different sections so as to drive it home in a way we can all relate to it, because I understand that we are all professionals from different backgrounds. So we will look at what antimicrobial resistance is. We'll look at a brief history about the evolution of AMR, where we started from, how we got to where we are currently, both globally and within the Africa context. We'll also look at some key lessons that we can take from the past, and we'll look at the current state of antimicrobial resistance currently in Africa. Then we'll also look at the opportunities that are available that we can explore to strengthen the AMR action in Africa. So what is antimicrobial resistance? Basically, antimicrobial resistance is when microbial agents, drugs, medicine, when they lose their effectiveness, that is, when they are no longer effective against the microbes that they used to be treated against. So that is like, I'll try to break it down as much as possible, because again, I understand that we have people from different fields on this call. So it is just to say that a drug, an antibiotic, for instance, used to treat, let's say, a respiratory infection, and all of a sudden the medicine is no longer effective against that infection. It can no longer, even when it is used for the right number of days, it is no longer working. So we can say that such the microbe, that's like the infectious pathogen that was responsible for that infection, is now resistant to that particular antibiotics. So of course, antimicrobial resistance is a very broad term, which includes antibacterial, antiviral drugs, antifungal drugs, antiparasitic drugs. But because antibiotics, again, they are the most common class of the microbial agents. So we try to we use antimicrobial synonymously with antibiotics. So we can say, instead of saying antibiotic resistant, we say antimicrobial resistant. So we use it synonymously like that, even though we can also say that all antibiotic resistance, they are antimicrobial resistant. But of course, antimicrobial resistance is not restricted or limited to antibiotic resistance, because we also have antivirus resistance, we have antifungal resistance and all. So I hope that is clear. I just really needed to point that out. And just like I was saying, for the sake of this class, for the sake of this lecture, we will be focusing on antibiotics. So, but again, like I said, antibiotic resistance in this context is synonymous to antimicrobial resistance. So I hope that background is clear. So I just need to give that background information. So I've defined what antimicrobial resistance is. So why is antimicrobial resistance a problem? Antimicrobial resistance is a problem because it makes infection harder to treat, just like the illustration I started with. You know, you used to use, let's say, you used to use cephalosporin, for instance. Let's say just one of the first generation cephalosporin. Okay, let me use cefazolin, for instance, to treat a particular infection, and then it is no longer working. So the fact that it's not working, that means the infection will persist. And then you start looking for alternatives. Okay, what else can we use? What else can we explore and all that? So at the end of the day, it makes infection harder to treat. And a lot of times it leads to more morbidity and mortality cases, so that we have more people come down with infection. We have more people die as a result of infections that could have easily been treatable. Because there is now a case of resistance, it becomes very difficult to treat. And at the end of the day, people tend to stay longer in the hospital. The productive time the time they're supposed to use in their offices, in their businesses, the time that the students supposed to use in school, they are in the hospital because of infection that could easily have been treated, except for the development of resistance. So, and again, longer hospital stay does not come at no cost. This is Africa. Many of us are in Africa. So you can relate. The longer you stay at the hospital, the higher your healthcare cost is. So you would see that antimicrobial resistance is a problem that is not just restricted, does not just have health implications, but has economic implications, because at the end of the day, there is higher healthcare costs. So the patients will spend a lot more. So what happens to people that cannot afford such treatments? Do they die from the infection? People that cannot afford more expensive antibiotics as a result of maybe like they would have easily used the first generation cephalosporin, for instance, and now they have to use third generation cephalosporin, fourth generation cephalosporin, which are usually more scarce and also more expensive. So these are the problems with antimicrobial resistance. So now, what are the drivers of antimicrobial resistance? We have talked about the problem. What are the things that contribute to antimicrobial resistance? The first thing that to antimicrobial resistance is when we talk about the misuse and overuse of antimicrobials. And the misuse and overuse of antimicrobials is not just within the human health sector. It extends to the animal health sector, even to the environmental health sector. So I know that a lot of our previous speakers, the person from the FAO, from the WHO, have talked about One Health, and that is where my presentation would end this evening. One Health, because antimicrobial resistance is not just a problem with some particular sector; it cuts across. The misuse and overuse of antibiotics by humans, it comes back to affect the misuse and overuse in the animal sector. It comes back to affect. Of course, I'm a veterinarian and I can say a lot more about that, but we are not going to lay so much emphasis on that this evening because of time. But I want you to know that it cuts across everywhere. So the misuse of antibiotics in the human health sector, the misuse of antibiotics in the animal sector, the misuse of antibiotics in the environment, the improper disposal of unused antibiotics that find its way to the environment, it would eventually come back to your table. Okay, now I was trying to explain very briefly so that we can. Again, I know that we have people from different backgrounds on this call, and that's why I will try to give you a practical example of how one leads to another. Okay, so now let's talk about a normal household. And because of lack of information, not lack of knowledge and all, they use antibiotics. They do not finish the antibiotics and then they dump it in the environment, improper disposal. So now you would agree with me that in Africa we do a lot of household animals, even farmers, they are everywhere in our neighborhood. So some of these people that we call them now, that people that engage in pastoral farming, that move livestock from one place to another, and then they just go from this place to another, and one way or the livestock, the cattle, the pigs, and all of them, they are grazing in that particular environment. So somehow they find a way to ingest the disposed antibiotics in the environment. They find a way to ingest them into their system. And again, because of lack of understanding, lack of knowledge, the farmer is not observing withdrawal period. Withdrawal period is the number of days that you are supposed to wait before you slaughter an animal or before you sell, extract and sell your meat products, so that the residue of that antibiotics that was taken into the system of the animal, it would have been cleared off completely, excreted out of the system of that particular animal. They are like completely taken care of. So withdrawal period is the minimum number of days that is required for that. So the farmer, as a result of lack of understanding, does not observe that. The person just slaughters the animal. So another person now just go to the market, you buy, you say, I don't use antibiotics, so I should not have any problem with antimicrobial resistance and all that and all that. But indirectly, you are consuming it from the beef you are eating. Because one person dump carelessly in the environment, and then some animals picked it up, and then one way or another, it ends up on your table, it ends up on my table. So with that quick illustration, can you all relate with how misuse and overuse of in one affects the other? It is all very linked. Microbial resistance is not an issue that we can fight in isolation, and that's why I'm so excited that we have different professional groups on this call. So I've talked about misuse overuse of antibiotics as a driver of antimicrobial resistance, poor infection prevention and control. Of course, many infections are not well managed. It makes it very easy for infections to spread from one person to another. And we are talking about even drug-resistant infection in this case. So it becomes a challenge, it becomes a problem. And this way, infection keeps spreading. These drug-resistant genes and pathogens, they keep spreading from one person to another. And AMR keeps going from one person to another. And especially in these days of global travel, I can wake up in Nigeria and by evening, I'm already in Germany. And of course, when I do that, I travel with all of my pathogens. And these are the things that make it very easy for antimicrobial resistance to spread. And that is why we have gotten to where we are currently now. And the lack of awareness and education, I talked about that before. So a study that was conducted in 2019 made us realize that antimicrobial resistance was associated with about 5 million deaths. 5 million deaths. You can imagine that. And 1.27 million deaths that were directly linked to antimicrobial resistance. So this is true. Of course, there are projections. There are projections that AMR could cause 10 million deaths annually by 2030. And 2030 is just how many years away. I would actually like to see the chart. I want to see how it is. So 2030 is how many years away? So I'm looking at the charts. I want to see the responses. 5 years, yeah, Ibrahim, it's just 5 years away. Just 5 years. And You can imagine. So these are the projections that by 2030, 10 million people will die annually from antimicrobial resistance. So this is actually to say that antimicrobial resistance is a problem that is waiting to happen. It is already here. Some 5 years ago, when I was still in school, we used to say antimicrobial resistance was a global pandemic. No more. It is no longer, no, we used to say it was a silent tsunami. Antimicrobial resistance is no longer silent. It is everywhere on our faces. And that is why yourself and myself, we really need to wake up. We need to really get on it. We cannot continue to wait. We need to start being actively involved. We cannot continue to leave it to some people. So now let us look at AMR through time. In 1958, Alexander Fleming discovered penicillin. I know many of us know all of this history, so I will not spend so much time on them. So when Alexander Fleming discovered penicillin, it was everybody was excited. By 1940, there was widespread production of penicillin. He saved a lot of lives during the World War II. But interestingly, in 1945, Alexander Fleming himself, he came to offer a warning and said, this our what do I call this our treasure that we have newly found. We really need to be careful in the way we use it, because if we do not use it, it can lead to pathogens that cause infections, can actually develop resistance to this our golden treasure we have newly discovered, and it would lead to ineffectiveness of this drug that we just. Not so long from that morning, we started hearing reports of resistance. By the end of 1940, there was already a report of Staphylococcus aureus resistance. Between 1950 and 1960, of course, that's what we call the golden age of antibiotic discovery. Golden age, why? Because new classes of antibiotics were actually found and they were developed. However, by 1970, between 1970 and 2000, we started recording all manner of resistance, all manner of multi-drug resistance, ESBL, methicillin resistance, Staph aureus, all manner. However, in 2015, WHO developed the Global Antimicrobial Resistance Action Plan, which actually gave us different plans that countries, governments, relevant stakeholders could adopt to control and combat antimicrobial resistance. So now that is at the global level. Let's bring it home to Africa. After the colonial era, of course, people start making efforts bit by bit to put regulations to antimicrobial resistance and all. But the challenge is a lot of these regulations were weak. Even the ones that were strong enough and could have made things happen, the enforcements have been a challenge. Of course, I will get there later. So you see a lot of countries that have regulations that say, okay, these antibiotics should only be told, or they should not be given out without prescription. But you see a lot of people can, in many of our countries, antibiotics are sold over the counter. If you can relate with me, give me a thumbs up. Antibiotics are sold over the counter in a lot of countries, and these are supposed to be prescription drugs. So these are the issues in Africa, and because they are sold over the counter, it's very easy for anybody, even somebody that has cold, that has nothing to do with bacterial infection, no bacterial infection, just flu. You will see the person go to the pharmacist and go to the drug shop and say, I need antibiotics. And nobody would question the person, and the person would just get the antibiotics over the counter and use. You see, the antibiotic that the person is supposed to use for 3 days minimum, you see people use antibiotics for 2 days. Once they are fine, they just stop using it. Say I'm fine, I don't need it anymore. And all of these are the practices that contribute to antimicrobial resistance development in Africa. So those are the issues: inappropriate dosing, self-medication, incomplete regimen. Those are the issues. And another issue about antimicrobial resistance in Africa is the fact that there is limited laboratory infrastructure. The laboratory infrastructure, they are so limited. And even the ones that are available, they are expensive. They are expensive. Somebody is sick, the person is dying, and then the person needs to do culture and sensitivity tests to find out, okay, what antibiotics would take care of this bacterial infection this person is dealing with. But before the result of the culture and sensitivity test is out, it takes 3 days. So do you expect number one, the person may not be able to afford it. How many people can afford culture and sensitivity tests? Even the ones that can afford it, it takes time for the results to be ready. So those are the issues. And because of things like that, a patient is dying right in front of a physician. The person will not say, wait, I will not use antibiotics for you until after 3 days when the result is out. No. The doctor will be forced to prescribe maybe a broad spectrum antibiotics for the person pending the time that the result of the culture and sensitivity test will be out. These are the issues. Empirical antibiotic prescription. And those ones are for the people that actually go to the hospital. Let's talk about the people that don't go to the hospital, which are actually, they are the ones that are more in numbers. You would agree with me that there are a lot of people in your neighborhood that they will just wake up one morning and say, because they are feeling some kind of pain, because they are feeling one kind of, they have gone to the pharmacy, they bought antibiotics. Nobody is questioning anybody. Those are the issues. And now we are talking about One Health. And again, I said, I know that there are people from different backgrounds. Even there are vets also even on this course. So now let's go to that area a bit. As a veterinarian, a farmer comes to you and say, my birds are dying. They are dying in tens of thousands. Culture and sensitivity result takes 3 days. Do you think the farmer will wait for 3 days without doing anything? And that is even the farmer that consults a professional. A lot of farmers just prescribe, they just use things by themselves. And these are the things, these are the issues with antimicrobial resistance in Africa. There are regulations, there are laws that say, okay, antibiotics should not be used without prescription, antibiotics this, antibiotics that, but the enforcement is, nobody monitoring nothing. So those are the issues with antimicrobial resistance in Africa. So of course, by 1990, I already said that before, a lot of resistant species were reported across hospitals and across different African countries. And these are the things that brought us to where we are currently. So I'll talk briefly about the global burden of AMR. I already said it before. I already talked about the research that was done in 2019 that was showing us the number of people that died as a result of antimicrobial resistance. And then the WHO GLASS reports in 2024 actually told us that 1 in 6 bacterial infections are already resistant to available antibiotics. That is where we are currently with antimicrobial resistance. And that's why I said the other time that antimicrobial resistance, I said it before that when I was in school, we used to say antimicrobial resistance is no longer silent. It is already, it is that you can imagine if 1 in 6 bacterial infection is resistant to all available antibiotics, that is a big problem. So what is the fate of people that have these infections? How will they be treated? Now, this is global reports. What about Africa? where there is limitation with resources, there is limitation with access to healthcare, there is high rate of poverty, that people can hardly afford even the normal antibiotics, let alone the last resort class. So these are the issues. However, it is not all problems. It is not all problems as the African continent. We have made quite some progress with antimicrobial resistance. So that is the good news. And that is to say that there is hope for us. And of course, we can even from here, we can do a lot better. And that is why we are having this call. That is why we are having this conversation. So we have made quite some progress, just as I said before. Over 45 countries have developed the National Action Plan on Antimicrobial Resistance. I said before, I talked before about the WHO Global Action Plan for AMR. So a lot of countries have developed their own national action plan. That is like the action plan that is specific to their own country. Like, this is global one. Now, I am in Nigeria. Okay, this is Nigeria National Action Plan. So we have over 40 countries in Africa that have actually developed their own national action plan. And that is progress. Also, the Africa Center for Disease Control also established the Antimicrobial Resistance Surveillance Network and the Regional Integrated Surveillance and Lab Network, which help to actually strengthen surveillance in Nigeria. The AMR net is actually human-based, but the Regional Integrated Surveillance and Lab Network actually link human and animal and environmental, like it is more or less like a One Health thing. So the effort of the Africa CDC is not just focused on just the human health, but it also cuts across the other sectors. And that, again, is progress. Also, we have the Fleming Fund that actually provided funds for countries to build their lab capacity, provided equipment for laboratory to improve surveillance of AMR across different countries in Africa. And that was really very effective. A lot of countries were able to develop their reference lab. A lot of countries have surveillance, good surveillance system in place and all. That is progress. And of course, because there is now a lot of countries are now better equipped when it comes to laboratory system and infrastructure, they can actually provide that for the WHO glass system. Like they can report data on antimicrobial resistance and all that. And again, that is progress. And when it comes to national action plan and all, I can say quite a bit about it because, like I said when I was introducing myself, my organization, One Health Course, is a WHO collaborating center. So we help, through the WHO, we help a lot of countries to develop the situational analysis that guide, like the situational analysis for antimicrobial resistance that shows the current state, the country context, the state of antimicrobial resistance in each of the countries. And then we also perform key informant interviews to interact with relevant stakeholders to find out what the problems really are, bringing it home now, and then we provide recommendation. And of course, they use this policy brief, this is situational analysis document to inform decision, to tailor solutions, and this, it guides objectives, it guides priority, it guides action for the development of the national action plan. So, and these are progress. Really, like I said, One Health Trust, we facilitated the situational analysis on antimicrobial resistance for Nigeria before the development of the NAP 2.0, that's before the development of the second national action plan for Nigeria. We do the same for Uganda, or we do the same also for Kenya. Even currently, we are working on the policy, working on the same for Angola, for Cote d'Ivoire, for Mozambique, different African countries, and we also do work with WHO for Asian countries too. But of course, we are talking about progress in Africa. So all of these are just to say that it is not all bad news. We are making progress as a country. So I hope I'm making sense. I hope you get my point. So however, we've talked about the progress we have made as a country. So what are the challenges? What are the things we are still dealing with? As much as a lot of countries have developed their national action plans, there are still quite some countries that have not yet implemented their national action plans. Don't even have, a few don't have national action plan, and some others are not implementing their national action plans yet as a result of limited funding, limited technical capacity, as a result of coordination issue, balancing sectors, the human health professionals, they are at loggerhead with the animal health professionals, the environmental health professionals, they have a business as regards what is going on, so there is coordination gap, everybody, difficulty in bringing people together. So these are some of the challenges in Africa. Also, ongoing misuse of antibiotics. I've already talked quite at length about that, so I don't need to like say any more thing on that. So, and also weak laboratory infrastructure and limited data reporting. So because there are not the laboratory infrastructures, they are weak. It is when there is a functioning lab, that is when you can take sample, and then that is when you can, okay, these are the resistant pathogens, these are the resistant patterns that we observe in our own region. That is when data reporting can be done. But when there is no lab infrastructure, nothing will be known. Nobody will know what is going on. And then fragmented surveillance, even regions where there are where their laboratories are equipped, most of them, they are concentrated in the hospitals and urban centers. So what about how many countries have well-equipped laboratories for veterinarians? So this surveillance, they seem to be focused on urban centers, hospitals, like human health. What about the environmental health? What about the animal health? What about the rural areas? So these are still areas where we need to improve a lot when it comes to controlling and mitigating antimicrobial resistance in Africa. And then again, just like I said, there are quite a lot of policies, but the implementation is also a challenge. So now, what are the lessons that we can pick from this? Unregulated antibiotic access. So long as antibiotics, they are not regulated, people will continue to abuse them. And when people continue to abuse them, antimicrobial resistance, it persists. So we need to find a way about that. We need to do something about it. We cannot continue to fold our hands and continue to look. And thank God I'm talking to professionals. So this also, it includes you, it includes me. And so it's even you as a professional, it is wrong for you to use antibiotics indiscriminately. And also the people around you, you can educate them, you can make them know that, okay, this is right, this is not right, this is not correct. These are the lessons we can pick from it, because like I said at the beginning, we all need to work together to tackle this challenge of antimicrobial resistance. Weak infection prevention and control systems. I think I mentioned something about that before too. It is very easy for people to acquire infection from the hospital when the infection prevention and control, when the system is weak. Health professionals can easily transfer resistant pathogens from one patient to another. Even patients can share it among themselves. So these are the areas that we need to focus on. Under investment in laboratories, I talked about that before. So these are things that we need to improve on. Fragmented One Health coordination. I talked a bit about that before also. Antimicrobial resistance is not a challenge that can be solved by some people. We all have to work together to actually solve the problem. So, and that is where One Health is. I am a veterinarian and a public health professional. A lot of you are pharmacists, other people are physicians, nurses, even the media people, everybody, health and non-health professional, we need to work together to solve the problem of antimicrobial resistance, and that is where One Health comes in. So, of course, regional and global turning points. I talked about a lot of this before, the WHO Global Action Plan on AMR and all of this. So these are the things that we can use to strengthen the current action on AMR in Africa. When we enhance surveillance, we improve infection prevention and control, we promote antimicrobial stewardship. You don't use antimicrobials indiscriminately. You do not encourage the indiscriminate use. So we also, of course, we also need to invest in workforce and diagnostics. I talked about that before. If cultural sensitivity is too expensive and people cannot afford it, so how do we get them to do the right thing? And also, another area we can strengthen current action in Africa is the youth-led and community-driven stewardship initiative. I know that previous speakers have talked about it, so I will not want to waste additional time on that. But everybody have said it, and I will also want to reiterate it, that it is in your hands, it is in my hands. Wherever we go from here, it all depends on every one of us. So we have to take responsibility. So in conclusion, antimicrobial resistance is a persistent, evolving threat. So, of course, we have learned from history and we have seen the pattern. We have seen how things have been over the time. So, Africa has established strong frameworks, of course, no doubt about that. But we need to turn a lot of those policies, we need to turn them to action. And One Health-driven approach is the way. Collaboration is the way. We all need to work together to make that happen. So in conclusion, I have it here that the lessons of the past are only powerful when they shape our actions today. And just like the theme of World Antimicrobial Resistance Awareness Week for this year is, it is act now, protect our present and secure our future. And that is what I'm saying to every one of us here. Let us act now. Let us protect our present and let us secure our future. So here are my selected references. Thanks for your attention.
Thank you so much, Doc, for a very profound, very educational, and very interesting lesson and presentation.
Chantel, your mic is muted.
Sorry. Okay, can you hear me now?
Yeah, I can hear you now.
Okay. So I was saying, thank you so much, Doc, for the profound, very educational and interesting presentation. I think if we are all to have the same passion, the same energy that Dr. Oluwatosin has when it comes to antimicrobial resistance, we can tackle the consequences and all the causes and everything that comes with antimicrobial resistance. And if we are to stop antimicrobial resistance, that means we are going to decrease the rate of mortality by the year 2030. So right now, before our breakout session, we're going to have a question and answer session. I think just 10 minutes. So please make your questions very brief so that we all ask our questions in 10 minutes. Thank you so much. So you just raise your hand and then we'll give you a chance to speak. Okay, so Mary, okay, you can ask your question. Mary, can you please ask your question?
All right. Thank you so much. I was not able to unmute earlier. So my name is Mary Cynthia Wangwa. I'm a pharmaceutical student from Nigeria, and I heard her talking about Miss Oluwatosin. It's really nice. It was an interesting presentation. I heard you talking about the when people have sick animals, instead of like letting maybe most of their animal die, maybe when they go to a pharmacy, or if they don't even go to a pharmacy, they tend to use the broad spectrum antibiotics, which can also lead to antimicrobial resistance. From my previous knowledge, or from the knowledge I had, I thought it was like the best way to go to like reduce on or turn down things, and it's more like I heard it was called empirical treatment. Okay, till they get the cultural and sensitivity result, they use the broad spectrum antibiotic just to lower the risk or the effect of having those animals die or human beings per se. So I don't know if you think that's is a wrong idea. Clarify, what do you think is the best way to result is yet to come out, and there is a potential risk of death if these animals are not being treated as soon as. So yeah, that's my question.
Oh, okay. So Chantel, should I proceed to answer that?
Yeah, it's okay. You can answer the question.
Oh, okay. Okay, all right. Thank you. So, of course, yes, that is the best way to go about it. But in the context I was referring to was I was talking about people that do not seek professional guidance. You know, let's say a farmer, the farmers, let me say a cow or a sheep, as the case may be, sick. A lot of times they just really feel like this was the symptoms I observed the last time. So most likely, and the vet prescribed them oxytetracycline. So let me also give oxytetracycline. No tests, no advice, no nothing, So it's in that context I was talking about. So they just feel like there is something in my local language we call bubunishe, broad spectrum antibiotic. They feel like it works for everything. I know you will agree with me that the fact that it's a broad spectrum antibiotic does not mean it works for everything. It does not mean it treats all infection. So it is abuse in that context I was referring to, not necessarily a professional giving a broad spectrum, pending when the results of the culture and sensitivity test will be out to now give a narrower spectrum antibiotics. And again, of course, you also know that talking about how these drugs work, I also made reference to adhering to the prescribed regimen, the number of days that an individual is supposed to use the antibiotics. So somebody that's supposed to use antibiotics for 3 days, for instance, just uses it for 2 days and says because I'm well now, or a farmer feels like because he needs to administer the same antibiotics to many animals and he wants to maximize profits. So it just says, okay, I've given them for 2 days. The animals are well, they are really doing well now, and let me just manage the rest of the drug so that I can give them the next time they fall sick. These are the things that contribute to antimicrobial resistance. So, Cynthia, did I answer your question? Is it clear now? Please confirm. Thank you.
Okay, I hope that's clear. So I'm just going to allow only 2 questions from Sir
Sorry,
Kelvin.
Chantal,
Sorry.
I'm really sorry to interject there, but for the sake of time, I was thinking maybe we can keep the questions for the end of the session. Maybe they can just type in their questions in the chat box and then we'll attend to them after the last speaker because we are running out of time.
Okay, it's okay. So the questions that you guys had for the session, just type in the chat box, and then we attend to the questions after that session. So now we're going to move on to a very short icebreaker that's going to be led by my colleague, Boy Tumelo. Yes, so he's just going to have, I think it's about 10 minutes, then you have the third session. Thank you.
Okay, thank you so much for the floor, Chantal. Hi, everyone. My name is Wikiman Malapani, and I'll be your last co-host for the day. So we're supposed to have play a quick game, but for the sake of time, I was thinking maybe we can have our speaker do the presentation, and then we'll do the rest after, because time is not on our side anymore. So with that being said, I'm just gonna quickly go through the next speaker's biography, and then they'll take the floor and do the presentation. So our next presenter is Prof. Muffin Mpundu. I hope I'm getting the names right. As a dynamic and results-driven public health expert with extensive international leadership experience in One Health, AMR, Global Health Security, Infectious Disease and Policy Development. He is the co-founder and executive director of REACT Africa. He is a member of WHO Strategic Technical Advisory Group on AMR. He's exceptional at spearheading strategic initiatives, securing and driving impactful health policies across global, regional, and country levels. He is recognized for expertise in One Health, pharmaceutical supply chain management, biosecurity, and health diplomacy, with an extensive network across governments, nonprofits, and academic institutions. Adept at leading high-profile collaborations with the USA, WHO, World Bank, African Union, and regional economic communities to develop and implement policies that improve global health outcomes. He's an accomplished speaker, mentor, and published author, shaping the future of public health. He is Professor of Global Health, City of London, and Imperial College, UK. Prof, the floor is yours.
Good afternoon, good evening, wherever you are. It's an honor to join in and have and make a presentation the last of the day. I know when a day has been busy, you have folks trying to check out and are tired. I'll try to make this quite sweet and brief. If you can allow me to share my presentation, that would be great. Yeah, I would like to congratulate the conveners of this meeting and this workshop. It is excellent that you are doing that in the WOW week, and congratulations. We're glad to partner on this important topic and important outreach to pharmaceutical students around the African continent, but also I'm sure we have folks that are joining around the globe. The topic that I was given to address was antimicrobial stewardship across the One Health spectrum, and that's what I'll try to focus the next few minutes on. We have had a few presentations that have alluded to One Health and that have tried to define it. But if I had to give it a technical definition, is that really One Health is an integrated, unifying approach that aims to sustainably balance and optimize the health of humans, animals, plants, and ecosystems. It recognizes that health of humans, domestic and wild animals, plants, and the wider community and the wider environment, including ecosystems, are closely linked and interdependent. At the heart of One Health is the concept that we're looking that we maximize and achieve the best outcomes in health for humans, animals, plants, and the wider environment, including wild animals. It is critical that we do focus on protecting and preserving and achieving the goals of health across the sectors. And I think it is important to recognize that 60% of the infections that occur in humans have got an animal origin, and that is quite critical. And every year we've got about 5 new human diseases that appear, and there is this larger contribution and the connectedness with the animal health, which is quite critical for us to actually understand. So why One Health? Why should we even bother to look at an approach in stewardship, in antimicrobial stewardship, that has a One Health outlook? It is quite important to realize that the way that we actually approach antimicrobial stewardship and these interventions, they require a multi-sectorial approach. They require multiple disciplines that include disciplines in the environment, in the animal and in the human sector, that collaborate and that communicate amongst each other, involving society as it were, to get the better outcome. So it really requires the mobilization of different sectors and disciplines to work together to be able to foster this great outcome of healthy communities, of healthy environments, of actually healthy animals, and I mean healthy aquasystems, as it were. And so One Health really promotes a sustainable and a healthy future through the collaboration, the communication, and capacity building across the sectors. You might ask then that, so what are some of the the One Health drivers in terms of antimicrobial resistance? Here we see that there's the drivers in the different sectors can be quite similar. In the animal sector, for example, we have a larger contribution, towards AMR by the farmers as they use antibiotics as growth promoters, as they use them for treatment, as they use a feed that is laced with antibiotics. We look at the contribution of wild animals, the agriculture, aquaculture, again, where we have seen an increased use in antibiotics in these actually sectors. In the human sector, again, patients are one of the major drivers as they take these molecules, as they buy them over the counter and they use them, as we see the pharma industry pushing prescribers to prescribe more antibiotics. And also we see the individuals that contribute by the misuse of these precious molecules. In the environmental sector, we look at the pollution that occurs from the pharmaceutical industries in terms of the effluents that are coming out of production units that are not treated. They get into the environment, they contaminate the environment, and we use that environment for agriculture, for growth, managing our farms, our vegetable farming, and equally polluting the water systems. And so our drivers actually can be quite diverse. This graph here shows us the contribution of the the different drivers that drive up antimicrobial resistance, as it were. So some of the things that we see, or the contributions that we see here, for example, we have the environmental sector that has got a moderate contribution towards antimicrobial resistance. Mass drug administration for human health does contribute. Suboptimal vaccinations, where we have vaccines, for example, in humans, where we don't complete like the multi-dose vaccinations that need to be given, for example, 3 vaccines over a period of time, and one only takes 1 vaccine, they are predisposed to more infections, and the likelihood that they're going to use antibiotics are quite high. But what is quite significant, I would like to point out here, is the fact that the larger contribution and the larger driver of AMR is the misuse and overuse of antibiotics and other antimicrobials in the human and in the animal sector, making the point that what drives antimicrobial resistance largely is actually human behavior. When we look at the global antibiotic consumption and use, we see that in this graph, we are seeing that North Africa and the Middle East in 2018, they consumed the highest quantities of antibiotics, with the lowest levels that we're seeing in sub-Saharan Africa. And in 2018, again, we saw that there was an increase in the consumption of antibiotics that we measure by measurement that is called the defined daily doses per 1,000 population. We see that that was actually quite high, and there was a variation that the quantities that were consumed were from different classes of antibiotics. Not one class was consumed more than the other in terms of the global picture. But also what we saw is that between 2000 and 2018, there was an overall increase by about 46% in the consumption of antibiotics. And in low and middle income countries, we saw an increase of around 76, over 70%, really 76% to be actually accurate in terms of consumption and use in the same period. When we look at the different classes of antibiotics and ask the questions, which antibiotic classes are being used the most? Between 2016 and 2023, we see, for example, that the broad-spectrum penicillins were used more than cephalosporins, more than the macrolides, more than the the fluoroquinolones and the tetracyclines. We see that these classes of drugs, consumption actually went up significantly in some of the cases. When we turn our focus into the animal sector and look at the consumption, what we see here is that for every chicken that we consumed, or you consumed, they collect 1 kilogram of a chicken consumed, we were consuming 35 milligrams of antibiotics. And in cattle, a kilogram of meat, we consumed around 60 milligrams of antibiotics. In pigs, about 173 milligrams of antibiotics. And in sheep, we saw that we consumed more antibiotics, 243 milligrams. This is exposing our bodies, exposing the bacteria that we have to these concentrations of antibiotics, and they start finding ways of surviving in the presence of these antibiotics. And largely, it is important for us to take note that, over 60% of antibiotics that are used in the human health sector are used in the animal sector. Antimicrobial stewardship is quite key, and I think the previous speaker made the point. It's one of the most effective interventions that we have in addressing antimicrobial resistance. And antimicrobial stewardship is a coordinated approach that promotes the responsible use of antimicrobials across humans, animals, plants, and the environment to ensure that they remain effective now and in the future. There are some key principles towards this responsible use. And one of the keys and the reason we promote antimicrobial stewardship is that it does promote responsible use. It does promote rational use of these molecules, or appropriate use of these molecules, that they are used only when they are supposed to be used. They are used only for patients that need them, or for animals that need them, or for treatment if it's in the environment that needs them. That's where we use them appropriately. The other point is that of equity in access. By safeguarding the effectiveness of antimicrobials, we are assuring that there is an equitable distribution, equitable utilization, that only where they are needed are they going to be used. We talk about preservation, looking at protecting antimicrobial effectiveness for generations to come, because our behaviors today affect the effectiveness of these precious molecules. And the context does matter. Decisions must be made based on the local needs, the risks, the local patterns of resistance that we are seeing, and the local diseases that we are seeing, and where we have the highest burden of diseases. There is equally the point of shared responsibility, that we are in this together. Every one of us has got a role to play in stewardship. Patients, clinicians, farmers, students, including politicians, they've got a role to play. And why stewardship matters is that it does prolong the effectiveness of these precious molecules. It assures that the treatment outcomes are going to be great. It assures that we are investing in antimicrobial development. It assures that we are working across One Health. It assures that we are making economic savings, and that our countries, our hospitals are thriving. Our hospital systems and health systems can be strengthened, because we are not wasting money. We are not spending more money. The length of stay in hospitals is actually far much shorter and not longer attracting more expenditure. So why invest then in antimicrobial stewardship? There are compelling reasons. One of the major strategic goals in the Global Action Plan, including the National Action Plans, focuses on optimization of and use of antimicrobials in human and in the animal sector. And that's the objective strategic goal number 4. And I think this strategy has got low-hanging fruits. The solutions around stewardship are not as complex as some of the multi-sectoral work that we need to do across the sectors. We can achieve a stewardship by mixing regulatory measures and resource allocation, ensuring that the interventions that we are putting in are actually sustainable, and they are doable, and they can give us the best results that we need. We can also mix and invest in stewardship by focusing on behaviors and building in behavioral change models and interventions that target behaviors. We have seen how these interventions worked in TB and HIV and how successful they were. When we look at why make a case for stewardship and what are some of the drivers of stewardship? Some of the drivers of stewardship, include, and that make the case for stewardship, include antimicrobial access. Optimization of access is actually quite critical. The pipeline for antibiotics has quite dried. There are no new antibiotics that are coming on the market, and we need to work towards preservation of these antimicrobials and efficacy. There is a financial burden. There are increased costs that are associated where we don't have antimicrobial stewardship programs. We see that patients spend more. Health institutions actually spend more as if you're not responding to one antibiotic, you are moved to another. And the more expensive that they become, the more we spend in terms of costs. We look at the environment. Again, environmental sustainability becomes, another one of the key challenges and drivers. If we want to have a sustainable environment, we need to invest in stewardship. The rising antimicrobial resistance can only be arrested, or it cannot be contained, when we invest and when we practice stewardship principles. Public health and safety does contribute, and this unregulated use of antimicrobials, where you can walk into any pharmacy, mostly in the African region, you can walk at a marketplace store, you can buy from any unregulated, places and have access to these antibiotics and other antimicrobials that are precious. Some of the enablers for stewardship, including, having the government involved in setting up laws, in ensuring that there are regulations in place and these regulations are actually enforced, but also investing in technology, in new innovation, ensuring that, for example, we have a rapid diagnostic testing that will guide clinicians to actually identify what the causing, what the disease is, what the causing microorganisms are, and selecting the right treatment that targets that sort of microorganism that is causing the infection. We have here a number of interventions that do work. Not one intervention is going to be effective. We need a combination of interventions, and here we've got actually 7 interventions that that I suggest that are proposed here. Education and training is quite critical. Building capacity around antimicrobial resistance among clinicians, building this capacity in our health institutions, in our farming institutions, in our environmental practitioners are quite critical. Currently, most of the medical students that are graduating in medical schools, in pharmacy schools or nursing schools, they don't have a lot of knowledge around antimicrobial resistance, what causes it, what it is, what are the drivers, how can we contain it? They don't have a lot of knowledge around the stewardship interventions that can be implemented, and these are core principles that need to be built into the curriculums, and ensuring that there is a pre-service, the in-service, and we are actually building capacity even among the practicing clinicians and the practicing farmers and vets and all these colleagues. Audit, providing audit and feedback how the prescribing is happening. Are they following guidelines, and providing these back to prescribing, generating data from its surveillance. What are the common pathogens? What are the patterns of resistance are we seeing is actually quite critical and quite cardinal. Clinical decision support systems, ensuring we have guidelines in place, we have clinical resources, we have a core, like in a health system, the pharmacists that are really trained in stewardship and can actually make interventions and make recommendations. We've got formulary management, where some restrictions are put in place, where not every prescriber can prescribe, for example, antibiotics that are in the last resort group, but only the ones that are trained and that have got competencies in doing that should be able to prescribe. Optimization, ensuring that we are adjusting the dosages, we are changing and converting patients from IV medications into oral medications, what is called de-escalation in our field. Those are quite key, ensuring that the guidelines are available, and that we are getting the surveillance data, we're getting the consumption data, we are doing the antibiograms in terms of reporting. These are some of the key elements that are critical. So if stewardship is one of the easier interventions that we can invest in, why is it a challenge then in implementing in African countries? One of the reasons is there are health system barriers, and this is where our health systems are quite weak. We've got a limitation in access to quality healthcare. Most of the primary health care has eroded in most of the countries, and the first point of care is a drugstore. It is a pharmacy. Folks don't look at the hospitals, at the clinics as where they should go and be seen. We have a low level of health literacy levels in most countries. Most countries, self-medication and prescribing is quite is enormous. There are inadequate finances that would invest in health systems and strengthen our health systems. We look at the other challenge of supply chain and regulations. Again, here we are looking at that we've got, a weak supply chain actually systems where the capacity, for example, of our pharmacists to be able to focus, to be able to quantify, to be able to order adequate quantities, there are flaws in those sort of actually capacities. There's a higher prevalence of counterfeit and substandard antibiotics, antimicrobials that are prevalent in most of our countries. And there's limited enforcement of regulations. Almost in any country in Africa, you should not be able to access antibiotics without a prescription, but we know that we can have access to these even from registered and regulated pharmacies. So enforcement of regulations is quite weak. And then thirdly, professional capacity and capabilities. Again, here we don't have sufficiently trained healthcare professionals. We have got very few microbiologists, and in some countries, they have zero infectious disease experts that are trained on infections, that are trained on selecting the best treatments for this difficulty to treat infections. Guidelines are often absent in most health institutions, and the fear for litigation really forces most prescribers to be able to prescribe and bow down to pressures from patients who say, I want this antibiotic, and they'll go ahead and do that. Facility infrastructure is quite a challenge in most African countries. We've got limited limited laboratories, for example, that are able to identify, to isolate, and that are able to guide in the treatment, in the selection of the correct treatment of an antibiotic. We have got, paper-based documentations. Digitalization isn't in most of the health institutions, and these pose a lot of actually challenges. And lastly, there is limited cross-sectoral collaboration. We don't collaborate a lot across the sectors. For example, we could particularly use some of the laboratories, both for human samples and animal samples, but that collaboration does not take place. And there's a limited understanding on how to implement One Health. So what are the key components in achieving equity in antimicrobial stewardship, access, and implementation? This requires investing in these 4 areas. We have to be able to invest in the healthcare workforce and looking at those dynamics that contribute to stewardship, to access and implementation. We have to understand the various roles of those that are working in healthcare, understanding what their contributions or what they can do to actually address or to inform or to contribute in developing interventions around antimicrobial resistance. I think it is important to be able to really optimize and use the resources that are actually available. Especially, we need microbiology to be able to isolate, identify, and inform. We need a pharmacy that is well stocked. We need clinicians that are well trained. And of course, we need the political and the policy economy that supports stewardship. We need national action plans that support stewardship. We need a representation of the policy agenda that aligns these interventions and actually supports them. The communities are key. We need to raise awareness, build capacity. We need to invest in infection and prevention and control in communities. We need to optimize infection prevention strategies such as vaccinations and ensure that infection prevention in home and in healthcare settings is actually optimal. But we also need an intersectoral lens to equity. We need to consider race, ethnicity, gender, class, education, migration status, and other social determinants of health and how they impact health overall, because if we don't understand, we will fail to build interventions that take into consideration these sort of social determinants of health. When we are looking at the One Health framework of stewardship, addressing stewardship across the sectors, we have here, I try to show here where we can have some commonalities in interventions, both in the animal health, in human health, environmental health, and in plant health, by really breaking these down in 4 critical components. Prevention as a key component. If we can prevent infections, if we can prevent any pollution, if we can prevent, and pre-treat irrigation water, increasing crop varieties and restrict the use of medically important antibiotics, then we are getting somewhere. Innovation is very key, ensuring that novel therapeutics are developed. We've got vaccines, they're being used, diagnostics are developed, and they are being optimally used. Ensuring in the animal sector, again, that diagnostics, which are quite key, vaccines, again, very key there. Access, ensuring that we have equitable access of these precious molecules, and we have strengthened our supply chain systems. Those are quite critical. And again, we see the same thing in the environment, equitable access of best available technology for wastewater treatment and management are very key. And the last one is care, ensuring that we are informed, and the way that we use these antibiotics, they are guided by evidence and they are guided by information. So we can take a systems approach to expand AMS by creating champions at the local level, at the facility level, by providing resources and developing the convincing narratives on patient safety and cost advantages, looking at the at the economic cases that we make, but also ensuring that at the national level we are incorporating AMS. Into accreditation standards and into quality measurement. This approach is actually approaching it both from a bottom-up approach and taking a top-down approach in addressing and strengthening stewardship at the national level. In terms of reducing and controlling consumption of antimicrobials and AMR, in low and middle income countries, which most African countries belong into that group, we have to focus on two areas: on reduction of antibiotic use and reducing transmission. We have to be able to disincentivize prescribers not to go for profit. The retail pharmacists not to focus on profit, but to focus on public good. We should be able to make restrictions on who can sell, who can access these precious molecules. We have to have, high penalties in terms of high consumption, where the consumption is way off the mark. Because the higher we use these molecules, the more that resistance looms, and we predispose them to developing resistance. I did make, I think I cannot overemphasize education and building capacity, having guidelines in place and using preventive medicine. We have to prevent infections, both pre-harvest control and post-harvest control. It is important that we prevent infections to reduce the need for using antimicrobial resistance. So antimicrobial stewardship has not only been recognized through clinical work and clinical settings, but it is one of the recommendations that was in the political declaration at the at the high level meeting of the United Nations General Assembly, and we see this, that there is these are recommendations that are quite key if we are going to achieve a reduction of 10% of deaths by 2030. We have to be able to reduce antimicrobial use by using good stewardship principles, both in the animal and in the human sector. We have to use 70% of antibiotics in the animal, in the human sector out of the access group as a critical recommendation. And we have to ensure and strengthen that there is an increase in global access to appropriate use of antimicrobials in settings with the highest unmet need, and these are in low and middle income countries. And so this is really focusing on really appropriate use of these precious molecules. So how can the youth drive antimicrobial stewardship and address AMR? You are key in raising awareness in your campuses, in schools, in your communities. You are key in promoting responsible use and really honing in these messages that, only use these molecules when they are prescribed to you and use them as they've been prescribed to you. I think these messages are quite critical. You are quite key in preventing infections, in preventing, for example, hand hygiene, promoting vaccinations, as I've made the argument, and ensuring that there's good sanitation in your surroundings. You can participate in science, activities, by reporting misuse, collecting local data, and contributing in surveys are quite key. Working during this week of War Week, being involved in raising awareness, in debates, in rallies, in art, in sport, and ensuring that you mobilize your peers around antimicrobial resistance and becoming a youth ambassador around AMR. Just lastly, just to give an example, a few examples of the involvement of REACT Africa in stewardship. We support countries develop national strategies, national policies around stewardship. We support institutions develop guidelines. We support institutions in using artificial intelligence, digitalizing these guidelines and making them accessible through apps on a mobile phone, and ensuring that these sort of guidelines and documents and clinical decision tools are available to clinicians. We have a multi-country project that we are doing now that is called Antimicrobial Stewardship Program through Innovation, Research, and Education. This is a program that is aimed at promoting a responsible use of antimicrobials in hospitals, and it's a three-phase project. Phase one really involved conducting point prevalence studies, a situation analysis, conducting key informant interviews and focus group discussions to get a better understanding of why prescribers prescribe the way that they do. And then we had phase two, in which we developed clear interventions in behavior, clinical, economic interventions. And then in phase three, we are intervening. And the hope is that we can have actually an impact through this project that reduces and have an that reduces and contributes to the containment of antimicrobial resistance. And these projects are being done in Kenya and in Zambia. We've also introduced really AI interventions by developing a WhatsApp chatbot that is used both by clinicians, but also by patients and communities. And here, any community member can actually have access to real scientific data and information that they can use. They can actually type in a question, for example, what is an antibiotic? How can I use an antibiotic? Should I stop an antibiotic? What are the symptoms of, say, a respiratory, tract infections? And the chatbot is going to populate this sort of information to build capacity and strengthen our stewardship programs. So, in conclusion, really, we can have a One Health antimicrobial stewardship intervention that cuts across the sectors, because we are interconnected: humans, animals, plants, and the environment. The stewardship programs are unifying programs that ensure responsible use of antimicrobials across all sectors. More emphasis should be placed on prevention of infections. We are to promote vaccinations. We are to practice, good hygiene practices, biosecurity in the animal sector, preventing contamination in the environment, out of hospitals, out of the abattoirs, out of the pharmaceutical manufacturing industry. We're supposed to coordinate our approach and using the national action plans as guiding documents that support our interventions. And of course, we have to sustain the collaborations, ensuring that no one is left behind, and communities governments, all sectors are actually involved, and they are vital in containing antimicrobial resistance. And so the youth and communities are clearly, you guys have got a critical role in advocacy work, in raising awareness, and in promoting responsible use of antibiotics. This should not just end in this WOW week, but it should go beyond this particular week. Thank you.
Oh, thank you so much for the informative session, Prof. That was really great. Personally, I've learned a lot, and I think all of us we did. So, with that being said, I've got a few questions for you. So, I don't know if I can go ahead and just ask. So the first question would be, so in your years of dealing with AMR and advocating for stewardship, would you say we are making any improvements from the previous years until now?
We certainly are making progress. I think we have made some progress. Almost all the countries in the African region, for example, have now a national action plan. In terms of implementation, that's the challenge. I think implementation is not where it's supposed to be. So yes, we have made some progress. We're talking about this issue now than we talked about it in the past. But are we really moving at the pace way we should be moving? I would say that we are not. We are still taking baby steps as opposed to bigger steps as grown-ups. And so I think that we still have a lot of work to do in terms of raising awareness, in terms of strengthening the health systems, in terms of actually ensuring that we have strong supply chain systems in countries, in terms of ensuring that all the communities have got clean and running water, ensuring that we have more trained practitioners and staff that can work in the environmental sector, in the human sector, and in the animal sector. We are still way behind some of these targets. And if we are going to have meet the target that has been set of a reduction of 10% of mortality by 2030, I would say that we are still far away from that. We are not anywhere close to that.
Oh, okay. And then also, I feel like most of the things that you mentioned, they require financial resources, and you know how Africa is in terms of our finances. So are there any other alternatives maybe to, sort of approach this matter?
Yeah, absolutely. I think you are completely right. One of the challenges that we have in African countries are the limitation in financial resources. One of the recent studies that was done in terms of looking at the laboratories in the African region, we were found wanting that there are very few laboratories in most of our countries that can be able to isolate the causing bacteria or a microorganism that can be able to test the antibiotics that they can respond to. There are very few laboratories, and this requires a lot of investment in terms of money. We need lots of money to actually invest in that. Most of the communities that you and I are coming from, we don't have any clean running water in most of our communities. That requires a lot of government investment, community investments in ensuring that our communities have got clean running water. That is not fair. We look at the rural areas most of them, they don't even have a clinic. They don't have a hospital that is fully equipped, that is well staffed with human resources, and all these require actually financial investments. But I think there's a start where we can start. I think our government must be held responsible to be able to do better planning, to be able to actually commit certain amounts of money to these investments, because if in the national budgets they are not providing for these investments, then we are not going to move forward. They should start reallocating resources to some of these critical needs and preventive measures that are needed. Otherwise, without that, we are not going to move forward. And there are a number of ways of doing that. The co-planning between ministries, leveraging on already running projects that have got finances. We can be able to introduce a certain level of taxes at the government level, and those taxes, what is raised goes straight and strictly into investments into these critical areas that are needed, that need support in terms of mitigation and addressing antimicrobial resistance.
Okay, thank you so much, Prof, for that. So are we making any means to get investors on our projects now?
I think some of the countries now are moving towards encouraging the private, public partnerships, really encouraging the private sector to get more involved in supporting some of the activities that are in their national action plans. I think that is one of the areas. We cannot always depend on foreign aid. We have seen what has happened with global support in terms of foreign aid. There have been drastic cuts. We saw what happened with the US government that, really abolished USAID. That was the biggest agency and the biggest supporter of public health programs around the world. That was actually eliminated. And so there is a critical need in finding local resources, and that will involve tapping into the private sector, and really focusing and strengthening and leveraging on programs that are already funded, that have got some funding that is coming out of Europe and that is coming out of the other continents. And so I think we really have to rework. We really have to rethink, and we really have to invest and find the local money that we can find. And I think it's there. Mm-hmm.
Thank you so much, Prof, for that. We're gonna take the next question. Emmanuel Joshua, you can unmute.
All right. Thank you so much. Good evening, everyone. My question, basically, I actually have a reflection based on what Prof has talked about. So concerning the One Health in antimicrobial resistance combating strategy. So I and my teammates, we actually work on a kind of innovation that is One Health-driven antimicrobial resistance biosurveillance. But unfortunately, we were not picked. But what I actually want to ask is that what actions or strategies are the React Africa are they using to actually drive this One Health in antimicrobial resistance combating strategy? Thank you very much. That's my question.
Thank you so much for your question. I think it is it is an important question. One of the activities that we have had is that we have been supporting countries with the development and the revision of the One Health and National Action Plans. And so these national action plans, when we support countries, we take a One Health approach. That is an approach that looks at all the critical sectors and that support countries to build interventions that cut across the sectors. And so we support at the very high level development of these national action plans and national strategies. Also, we support countries develop national strategies, again, that take a One Health approach, whether we are addressing antimicrobial stewardship, we are addressing surveillance, we are addressing infection prevention and control. This is the approach that we take, and we've been supporting countries like that. But we also have actual projects that we run in different health institutions in different countries, supporting the setting up, for example, of stewardship programs. And these stewardship programs are programs where we are building capacities. We are setting up systems of stewardship. We are actually investing in innovation interventions, guideline development, protocols development, and training both doctors and nurses around AMR and around successful interventions. And so we are practically working in these institutions. We are also working in the animal sector, where we are promoting, biosecurity. We are promoting, again, principles of stewardship in a practical way. But further than that, we are working at the community level. We work with faith-based organizations. We work with churches. We work with schools. We work with institutions like universities, colleges, and primary schools, setting up clubs that focus on AMR and that raise awareness around AMR. And so we do have a holistic approach. We work at a very granular level. We do work at the provincial, the state level. We work at the national level, and we also work at the global level, where we actually highlight the challenges. We bring forward the needs. We bring forward stories about the progress that is being made on the African continent, and so these are the areas that we actually work on, and so we are really in the thick of things, as one can say, in terms of addressing antimicrobial resistance in the African region.
Thank you so much, Prof, for that. We see that you put in so much effort into combating this global health threat. You putting so much effort, and your efforts are not going unnoticed. We really appreciate that. We're gonna take the next question. What's happening? Oh my gosh. Do we have any more questions? Okay, it seems like we don't have any more questions, Prof. I think that would be that for today. Thank you so much for making time to be with us today. And, I know it took so much preparation so much time to prepare your presentation and actually be here with us today. Thank you so much for your time. And I think that would be that for today. So we're gonna move on to the last business of the day, which is playing a smaller game before we end the meeting. So to wrap up the session, we're gonna play a game called Two Truths and One Lie. So you're gonna give you three statements and you're gonna have to spot out the incorrect statement about antimicrobials. Next slide, please, Susan. So just to test whether we're listening or not, we are having the first question with 3 points. So the first point is some bacteria are now resistant to every antibiotic we have. Point B, antibiotics help cure viral infections like flu. AMR can spread between humans, animals, and the environment. Which one do you think is a lie? You can type your answer in the chat box, or you can simply raise your hand. Okay, that is true. B is incorrect. We don't use antibiotics to treat flu because antibiotics don't work against bacteria. So yeah, B is a lie. Let's move on to the next question. Suzanne, next slide.
It's on the next slide.
Oh, I'm still on the first slide. Gosh, what's
Because people are
happening?
answering, so it has moved. Hilary, are you able to see the next slide?
Yeah,
Oh,
I can see
no.
the next slide. So let me just read out the questions for the next slide since Butimena can't see. The first option is A. It says bacteria can become resistant if antibiotics are used too often, right? And then B says you should always finish your antibiotic course even if you feel better. And then C, AMR is nothing to worry about. So two truths and one lie. I'm pretty sure people are answering, the majority are answering C. C is false. They're saying AMR is nothing to worry about. And for sure, that's false. So next slide. Bitimela, just confirm with me if you can see the next slide now.
I'm still on the first slide. I don't know what's happening.
Okay, let me just move on. The next slide, AMR can spread from one person to another. B, only old people can get infections with resistant bacteria. And C, everyone can help reduce AMR by using antibiotics correctly. Which one is the false answer? I've got two different answers in the comments. Okay. It seems everyone is on board with me. Answer is B there. The next slide, okay, yeah, B, only old people can get infections with resistant bacteria. This is false. All right, the next slide, there are the options A, B, C. Animals can carry bacteria that are resistant to antibiotics. Good hygiene can help prevent the spread of AMR. Antimicrobial resistance makes antibiotics stronger. I'm getting different answers, but majority of the answers are indicating C to be the false answer. Antimicrobial resistance makes antibiotics stronger. That is false. Okay, we can definitely move on to the next slide. People are paying attention. Oh, it's done. So I'll hand it over back to my colleague Witimelo. She can take over from here.
That is it for today, guys. Thank you so much for availing yourselves. Let's do the same thing on the 20th. But before we log off, can we just quickly attend to the pre-survey form for the sessions on the 20th and 21st? Thank you so much. Good night.
Remember, the pre-survey form will help us be able to get your details to get certificate of participation. So make sure you scan the code. I've also sent the link to your emails. If you haven't, feel free to reach out to me. I'll leave out my email in the chat. And we'll see you on the 20th. Apologies for the ones in the Francophone countries. Today it was mainly English. On Thursday, we'll have separate for English, separate for French, so that you can engage properly, ask our questions, and have a good session. So yeah, thank you so much, guys. And also
Susan.
before you leave, you can have a picture session. Yes, Hilary?
Yes, I was just about to remind you about that. Just ask everyone to switch on their cameras so that we get onto the picture session.
Okay.
Yeah, I'm seeing a lot of, pretty faces, a lot of smiles. Please tell us when you're ready. Please tell us when you're ready.
Okay, let me stop sharing so that you can. Okay. Or for the form, you only fill it once. We'll have also a post-survey form, which will be sent now on Friday after the final session of the forum. So this pre-survey is to get what you join in for the next two sessions, and then post-survey will be evaluation of all the three sessions. Okay, I hope you're ready. I'll say 1, 2, 3, and then you smile. 1, 2, 3, smile. Okay, let's have another one before I've added. Okay. One second. Okay. 1, 2, 3, smile. Okay, great. Let me do the next page because we're many.
Cecilia, is everything okay there?
Okay, the next page. 1, 2, 3, smile. Okay, the last page. Okay, 1, 2, 3, smile. Just keep smiling because you're not sure which page you're on. So do you have another one? Okay, that's it. Thank you guys for joining, and I hope we'll come in numbers. Bring a friend for the Thursday sessions. It will be more interactive. You can be able to ask questions. It will be less of presentation and more interacting on AMR, that you can bring out your ideas, share what you have so far, what people can implement. And yeah, thank you so much. Have a lovely evening.
Brother Daniel, how are you doing? Brother Daniel. Yeah.